In part 1 of our mobility lecture, we defined the concept of mobility. We looked at characteristics of normal mobility. We looked at factors that affect mobility and some of the manifestations that we see of altered mobility. Now we want to turn our attention to the impact of immobility on function. Immobility has far-reaching effects on human functions, and a framework that really provides us a way of viewing those far-reaching effects is our functional health pattern framework. The functional health pattern component that is most commonly associated with immobility is the activity and exercise functional health pattern, which is detailed here on this slide, some of the impacts that immobility will have on activity and exercise. Obviously, with immobility, we see the loss of muscle or muscle atrophy and the related weakness. We see contractures or decreased functioning of joints and joint pain associated with that. Immobility increases cardiac workload. Another problem that we see with immobility is orthostatic hypotension. As you're aware, orthostatic hypotension is the phenomenon that occurs when someone goes from a lying position to a standing position and has a significant decrease in their blood pressure. And when people are immobile and we have a loss of muscle in the calf area, we actually will see a significant increase in orthostatic changes. This is because our venous return is really dependent upon the use of our leg muscles, particularly our calf muscles. And it is the massaging of our veins by the calf muscles through use that actually helps to promote venous return. So when we are immobile and we are not using those calf muscles, then we're not going to see that same venous return. We're going to see blood pooling down in the lower extremities, and particularly when someone gets up quickly, we're going to see that their blood pressure is going to drop. Another related problem is that anywhere that we see blood pooling, we are also going to see clots forming. And so there is an increased risk of thrombus formation, and if those thrombi choose to travel, we see embolism. Finally, in terms of activity and exercise, when people are immobile, we see a decrease in lung expansion, and that can come with a whole host of other problems that are residual from that. Another area with major impact from immobility is in our nutrition and metabolism functional health pattern. With immobility, we see decreased metabolic rate and a negative nitrogen balance. Oftentimes, people become anorexic with immobility. With our long bones, as they are not weight-bearing because of immobility, we will see a disuse osteoporosis. We also see effects on the bone marrow, and that ends up impairing immunity. So immobility actually is associated with increased infections. Another area in nutrition and metabolism has to do with skin health and the pressure ulcers that are often a result of immobility. Immobility also impacts elimination. Immobility is often associated with urinary stasis, which increases the risk of both UTI and of the formation of renal calculi or stones. In terms of bowel elimination, immobility is a direct contributor to constipation. When one is immobile and sitting still for long periods of time, the bowel follows suit and just begins to shut down. There are a whole host of others, other functional health pattern areas that are impacted by immobility. Sleep and rest, cognition and perception, self-perception and self-concept. Roles and relationships are affected, coping and stress tolerance are impacted, and sexuality. So I'm going to encourage you to see your Craven text for a discussion of all of these. as well as a summary table, table 25.2, kind of contrasting the effects of exercise with the effects of immobility on function in these different functional health pattern areas. I would also highly suggest that you review the concept map related to immobility, which is figure 25.3. So what we want to do to round out this discussion is to take this and put it in our nursing process framework. So when we're looking at issues around immobility, let's start with our assessment phase. We gather subjective data, and we, in doing that, ask people to identify their normal activity patterns, what their normal lifestyle might be, and to identify any dysfunction related to mobility that they are aware of. In terms of objective data, we gather a lot of information through physical assessment. We're looking at issues like alignment. We might be looking at, as this picture depicts here, at perhaps a lateral deviation of the thoracic spine, referred to as scoliosis, or perhaps lordosis, where there's a highly concave lumbar spine, or kyphosis, an extreme curvature of the thoracic spine. So these are all alignment issues that we assess for. We're also assessing for balance, assessing for coordination, and assessing gait. Our physical assessment also collects data on joint structure and function, assessing muscle mass, tone, and strength. As we mentioned before, checking postural blood pressure, assessing for risk for falls. And there are actually a lot of good tools out there to assess for fall risk. One of them that's commonly used, especially with the elderly, is the Heinrich 2, and that's actually a table 25.3 in your textbook that you might want to take a look at. And I would actually suggest that you either take that tool or Google another fall risk tool, and maybe use that on if you have, say, an elderly family member or a neighbor that you could assess for their risk for falls. It's a good exercise to actually take a fall risk tool and utilize that with someone. We also look at different diagnostic tests and procedures as part of gathering our assessment data. If there are x-rays, radiographic studies of some sort, perhaps there's been an arthroscopy done and we have a direct view into a joint, and we can read the reports about that. Or looking at blood work, particularly looking at hematocrit and hemoglobin, indicative of oxygen carrying capacity, which definitely has an impact on activity tolerance. Once we've gathered all our assessment data, of course, the next step is to formulate our nursing diagnoses. And there are quite a number of nursing diagnoses that are related to impaired mobility. You see listed here impaired physical mobility, impaired walking, impaired wheelchair mobility, impaired transfer mobility, impaired bed mobility, activity intolerance, and risk for disuse syndrome. All of these you should be able to look in a nursing diagnosis handbook or in your textbook and just explore what some of the nuances and differences are between these directly related nursing diagnoses to mobility. These are actually detailed in table 25.4 with some knocks and nicks there for you, the outcomes and interventions associated with these diagnoses. So again, I urge you to spend some time looking at that table in your textbook as well. As always, when we look at an issue, we don't want to keep ourselves in a singular focus, but we want to broaden our view as well. And here are just a few of many different related nursing diagnoses that we would want to consider if someone has impaired mobility. Not only are they going to have nursing diagnoses that are directly related to that impaired mobility, but we're also going to see some related diagnoses. For example, is there a self-care deficit? Many different types of self-care deficits that we may see related to a loss of mobility, whether it's a partial loss of mobility or a complete loss of mobility. Definitely impaired skin integrity will be a problem with people who are immobile for long term. We've talked about risk for falls and constipation as related factors, and certainly we want to make sure that we're not missing important nursing diagnoses that might be secondary to immobility. And some psychosocial diagnoses as well, whether that be powerlessness or disturbed body image, social isolation. These are just a few of the things that we want to keep in mind that might be related as we try to formulate appropriate diagnoses for our patients. Once we have our diagnosis, the next step is outcome identification and planning. Here are some general goals that would be related to impaired mobility. Of course, if you were going to use these for a patient, you would want to make them SMART, make them specific, measurable, appropriate, realistic, and timely. But some of the outcomes that you would be setting would have to do with increasing endurance or increased tolerance for physical activity, the ability to actively participate in prescribed therapies, a learning-related diagnosis might include an outcome about participating in measures to prevent complications of immobility and knowing what those are. So these are all outcomes that you would again want to be smartening up if you're using them in a plan of care. Once you have your outcome identified and start to make a plan, then we implement our interventions. There are a number of different types of interventions that we would be implementing. Some of them around the concept are focused on health promotion. This would be things like exercise programs, osteoporosis prevention protocols, injury prevention, those sorts of things that would be associated with health promotion. There may be positioning interventions that we would implement. Perhaps that's a turning schedule. Very standard in inpatient settings is that a patient would be turned every 2 hours, but that definitely needs to be specified to an individual. There also might be some special needs related to positioning. Managing clients who have just had hip surgery means rolling them to the unaffected side and then using a pillow between their knees to prevent adduction. Some people have a special need of keeping their spine completely straight, and so that requires log rolling as we reposition them. So we want to keep those things in mind with our positioning interventions. We also want to engage in joint mobility maintenance, active or passive range of motion. We want to use any equipment in joint mobility that might be helpful to us, such as automatic range of motion equipment or CPM machines. And there's a picture here in the next slide of a CPM machine that just constantly has continuous movement of an affected knee to just keep that range of motion. So that would be moving back and forth there to keep that knee flexing and extending slowly over time. We want to make sure that we are implementing safe transfers. We want to make sure that we are using lifts as appropriate, Hoyer lifts and other equipment, that we are using appropriate assistance. For some patients, when we are transferring them, it's going to take 2 or even 3 people to do that safely. So we want to make sure that we are doing that in a safe way. And then we also want to keep in mind community-based interventions. A lot of those have to do with client teaching, with assessing a home for safety, making sure there are ramps in place, making sure that there are no scatter rugs that might create a tripping hazard for somebody with an impaired mobility. Community-based interventions are also going to involve setting up home services and perhaps providing family support as well. Then finally, we're going to evaluate. last step of the nursing process. So here with the sample goal of the client will exhibit increased endurance and tolerance for physical activity. Again, that's not a SMART outcome. If you're going to use that in a specific patient setting, you would need to smarten that up. It's a sample guideline. And in order to evaluate that, some possible outcome criteria are listed here. Again, that would have to be specified for a SMART outcome. But this just gives you a little bit of a guideline of how we would go about evaluating. So that is a summary of this concept of mobility. Please enjoy looking in the book and increasing your knowledge on this subject.